Good
Okay.
afternoon. Good afternoon. Thank you for joining us, Payam. It is an absolute joy to have you back talking to us about biliary ultrasound again. Thank you for joining us. Payam is one of our ED staff specialists here at Nepean Hospital in Sydney, and he's doing his advanced qualifications in general ultrasound. And so it's a real privilege to have you here talking to us about biliary ultrasound. So Payam, thank you very much. The floor is all yours.
Thank you, Sam. Pleasure to be at. Just an introduction. I'm using this slides and education that a big part of it was prepared by my supervisor, Dr. Manuel, who is the DDU in emergency medicine. And I've added and tweaked some parts of it, adding some images and changing some parts of it to tailor it to what was described by Sam as what would be more suitable for the ICU DDU purposes. So generally speaking, I'm gonna go through a very brief anatomy, just what is needed, and then go through some scan techniques. What sort of images do we need for the hepatobiliary, and some common pathologies that most likely would be needed for the ICU DDU. And then at the end, I've got some images that we can go as interactive sessions together, some kind of YY style for image interpretation. So if you remember, obviously, when we are looking AP, we are having our stomach with the duodenum and the liver, the hepatic veins. What is important for us for the hepatobiliary scan is we have a quick look at the livers, the left lobe, the right lobe, both in two planes, sagittal and the transverse. Fanning through, just quickly look at obvious pathologies, especially for the ICU purposes, if there's any abscess or signs of malignancy, that sort of thing. Having a look at the venous pattern and the biliary pattern and the bile ducts and all of that. Then we have the gallbladder and the common bile duct and the portal vein. If we look at this side, there are right and left hepatic ducts which join together. They create the common hepatic duct. And then we have the gallbladder with its cystic duct. And when the cystic duct and the common hepatic duct join together, it creates the common bile duct, or the CBD. And then the CBD empties into the duodenum. Now, this is quite important because when we look at the hepatobiliary, again, we look at the pathologies of the common bile duct as we go through, and the CBD is important for us as well because a lot of pathologies cause CBD dilation specifically. With the scan technique, we usually do the hepatobiliary scan in two planes at least, in two positions at least, and I talk about the importance of that later on as well. One of them can be either supine or it can be slightly left lateral, and in either way we are looking at the hepatobiliary system in the trans and in the sagittal. A lot of times, if the patient is on supine, which would be the position for most ICU patients, I assume, the biliary system is completely behind the ribs and you won't be able to see it most often. If the patient is not tubed, then you can ask the patient to take a deep breath in and hold. That can help. Otherwise, if we can actually put the patient on the left lateral position, that can help bringing the biliary system off the rib cage, and we can see that that can help visualizing the biliary system. So that supine or the slightly left lateral would be the first position that we look at, and in that position, the neck of the gallbladder would be in the. If you look at the anatomy again, the neck of the gallbladder would be in the posterior part, which is the dependent part, And the reason we always put the patient in the either sitting position or standing position if we can, it might be not possible for the ICU patients, I understand that, but if the patient is not tube and you can do that, it's important to do that because if in the supine position, if there's a stone, it can get lodged in the neck. And with every stone, it's very important to see whether they are mobile or they are stuck in the gallbladder neck. And the only way you can say that is to change the position, make the fundus of the gallbladder the dependent part of the gallbladder so that the stone moves into the fundus, and then you can see, okay, there is no stones lodged in the gallbladder, or if there are stones in the gallbladder, they are mobile. Because obviously if the stone is lodged in the gallbladder, there's increased chances of causing cholecystitis and other pathologies. So generally speaking, when we are looking at the gallbladder, we are looking at something like this in the long view. We are having the liver there, we are having the gallbladder, all the way there. Bowel gas, that would be the fundus, that would be in the neck, and it's very important again to visualize the neck in the long view, and obviously we fan through all the way from left side to the right side or vice versa to see the gallbladder in a hole in the long view. Then we are having a glimpse of the CVD and the portal vein there, and again some gas there with the shadow of the gas. Now, here again, we are now to open up the CVD. Usually, if you want to open up the CVD, if you go, let's go back to this view. If you go pretty much mid-axillary and have your probe marker towards the head, but instead of the 12 o'clock, if you put it at the 11 o'clock, so it's slightly towards, not completely towards the right shoulder, just at 11 o'clock, you should be able to see the CBD and the portal vein below it if you fan a little bit. But obviously there is some sort of anatomical variations, but usually it's at 11 o'clock marker. Now, as you can see two tubular structures, one on top, one at the bottom. So this would be the posterior, anatomically posterior part. This would be anterior part. With the CBD, there are several things. As a general rule, the bile ducts and the portal vein both have, although the portal vein is a vein, but it has same sort of appearance as an artery with bright, thick walls. For example, if you look here, you can see hepatic veins, and you almost don't see any walls. It's just a black tube, almost no walls, and that's the hepatic veins. But with the portal vein, you can see those bright lines. Same for the CVD. CVD has bright walls. Now, that causes a kind of a possible pitfall when you are scanning, and that is, again, if you look at the anatomy, when you are looking anteroposteriorly, we see a tubular structure at the posterior part, which is the far field of the screen, which is the portal vein. And then we see another tube on top of it, the way it would look like here, which can be either the CVD or the hepatic artery. And in the normal situation, they both are pretty much the same size. And as I said, because the CVD has bright, thick walls, it can can look exactly similar to the artery. So technically, they can be mistaken to each other. And as you can imagine, if you are looking at the hepatic artery on top of the portal vein instead of the CVD, and you think that it's the CVD and you measure it, it's going to be the normal size for the CVD. And your real CVD might be completely dilated. So the way to differentiate it is obviously we use Doppler. And in the CVD, you expect not to have any Doppler signal. And as you all know, pretty much by adjusting the settings, if I decrease the Doppler gain and increase the, if I adjust the settings enough, I can make any sort of flow to disappear. So that's important because then again, you might not see the flow. You think that it's the CVD, but it's just because of your adjustments. So the way that we just make sure that that is not the case is we make sure that our adjustments, including the Doppler gain, is in a way that we do see the flow in the portal vein, which should be towards the liver. And although we are seeing the flow in the portal vein, we shouldn't see any flow in the CVD. The logic is that obviously if that was the hepatic artery, definitely if the setting is enough to pick up the flow in the portal vein, it would be definitely enough to pick up the flow in the CVD. So
so it's also interesting to see that you've got the scale right the way down at 7 on there as well. So that will make it light up.
Yeah. So if you just, because if you increase the scale, technically you can make any sort of, even we can actually make the aorta look like there is no flow in it if you increase the scale enough. So you put the scale down, you increase the gain enough to get the flow in the portal vein. And if that's the case and there's still no flow in the tube on top of it, then that's the CVD. And you measure it from inner wall to inner wall, so just the inside diameter. And usually the normal range is below 6 millimeters for people who do have the gallbladder. If you have cholecystectomy, it can go up to 10 millimeters in the normal situation. And in the elderly, technically, usually the age above 60, the general rule of thumb is that we divide age by 10, and that would be the upper limit of the normal diameter of the CVD. For example, if you have an 8-year-old patient, even without cholecystectomy, the CVD might be up to 8 millimeters. The other thing which is important to understand is some normal variants. For example, the gallbladder can have some folds. And you can see these folds by fanning through the gallbladder, especially in the longitudinal view. And if we don't do that, we might think that, for example, the gallbladder finishes there, but actually this is just a fold in the gallbladder. And because it looks like a Phrygian cap, sometimes I call this as the Phrygian cap. And again, there's another importance to it that I will mention in the future slides. The other normal variant which is important is the contracted gallbladder. So somebody who just postprandial patient with contracted gallbladder, the wall might look like thickened, and you might and the thickened wall is one of the criteria for cholecystitis. It's quite common to misinterpret the thickened wall of the gallbladder as acalculous cholecystitis. And again, the normal thickness for the gallbladder is usually less than 3 millimeters, but in the contracted gallbladder, even if it's normal, it can be a bit more thickened than that.
Sorry, Payam, that's just like it is in the heart as well. So we talk about pseudohypertrophy in the heart with an underfilled ventricle, that the walls look thicker and are a little bit thicker. So it's exactly like that. Oh, cool.
Yeah, exactly same thing.
No, pseudohypertrophy. No.
Yeah. So the other thing that we look at is the gallbladder diameter. So usually the biggest part of the diameter, less than 4 centimeters, is normal. If it is more than 4 centimeters, again, it can be pathologic, for example, some sort of obstruction, but it can be some morphological variant, fasted patient, different anatomy, for example, in the diabetic patient with atonia. Or elderly patients can have distended gallbladder and empyema. So this is, for example, for us, this is a quite common exam question that they would just say list the differential diagnosis for large gallbladder, as in dilated gallbladder. Now, the other pathology is obviously the cholelithiasis with a stone. And with the stones, usually we see a hyperecho area with its shadow posteriorly. Now, as you know from the ultrasound physics, the only way, there are some pitfalls to it, because for example, if the stone is less than the beam width at the area that the stone is, technically you might not see a shadow. If it just, the size of it is smaller than the beam width. And that's important because we need to put the focus at this, where the stone is, and that's when we can actually see the shadow. If you put the focus on top of it, especially, or the bottom of it, you might not see the shadow, or if the stone is too small. And usually the stones are pretty much mobile. They can be stuck in the gallbladder, but more often than not, they are mobile. Now, they can come in different sorts of shapes and sizes. They can be very big, lodged in the gallbladder. So if it was a little bit smaller and lodged there, you could easily just not see it, as in thinking that, okay, this is the gallbladder and this is the wall of the gallbladder and it's the stone. But again, looking at the shadow of it, it makes it a bit more obvious. The other trick is, I personally, usually when I'm looking at the gallbladder wall, I make the depth a bit bigger, a bit deeper, increase the depth, so that I can actually pick up any sort of shadow of the stones. Because if, for example, you put the depth at here, just looking at the gallbladder wall, you might not see that shadow and you might think that this is just the gallbladder wall. And there might be multiple small stones like this with the shadow posteriorly after that. The other thing that you might see is a huge stone filling pretty much the whole gallbladder, and you might look and you might think, okay, there's no gallbladder there, thinking that this is just a bowel loop, because pretty much the bowel loop would almost look like the same thing, as in a bright line with shadow after it, with some differences. The other thing that might look like similar but a bit different is calcification of the gallbladder wall, which is called porcelain gallbladder. The difference that can help us differentiate between all of these situations is a thing called WES, wall echo shadow phenomenon. And that is this wall echo, that black area, and then shadow afterwards. So this combination of the gallbladder wall followed by echogenic area followed by another hyperecho area with its shadow called WES. And again, that is another common question in the DDU exam for us, at least, to mention the differential diagnosis of the porcelain gallbladder or a big stone in the gallbladder and how you differentiate these two. And that is the porcelain gallbladder. And as you can see, it's just a white sort of hyperecho wall without any echo, without any pretty much anechoic area between the wall and that shadow. It's just one sort of echogenic area with the shadow after it. And that would be an X-ray of the porcelain gallbladder. With the porcelain gallbladder, the other thing is that you might see the posterior wall. If that was a big stone, you wouldn't see anything after it. It would be just one hyperecho area with complete shadow after it and nothing in the middle. But with the porcelain gallbladder, because some of the ultrasound wave still passes that calcification of the gallbladder wall, you might see the posterior wall. But this may or may not happen. Sometimes with the porcelain gallbladder, you just see one echogenic wall, you don't see the posterior wall. That's another example of the porcelain gallbladder. And in this one, for example, because calcification is not that bad and some of the ultrasound wave passes through that wall, you do see the posterior wall, but in this example, you don't see anything in posteriorly. But both of them are porcelain gallbladder, none of them are stone. Now, there are some mimics to the stone. Again, very common question, as in what would be the differential diagnosis and pitfalls for the stone. One is the duodenal gas, that you would see that there is a echogenicity there with some shadow after it. And that brings us to the phenomenon of dirty shadow versus clean shadow. So technically there are different physics mechanisms for them. With the clean shadow is pretty much the attenuation of the ultrasound wave. So you get the surface area which is very echogenic. It just echoes back almost all of the ultrasound signal, the ultrasound wave, and nothing passes through. So this is completely dark afterwards. With the dirty shadow, there are different mechanisms. If you look, it looks very similar to the B lines in the lung when we have any sort of interstitial fluid. And the mechanism is almost the same. So it's a kind of a reverberation artifact, okay, from that gas area, which is usually different levels of gas very close to each other, which can cause reverberation. And that's pretty much same sort of reverberation artifact, similar to what you see in the lungs that we call them B lungs. Sometimes it's very obvious like this. Sometimes they are not that obvious like this. And the other thing is with the clean shadow, sometimes, well, obviously if you increase the gain enough, you can see the echogenic material even in the bladder itself or in the urinary bladder or any kind of completely fluid-filled bladder. So it's, depending on your settings, you might see a little bit of echogenicity in the clean shadow, but as a general rule of thumb, it's a much darker area in comparison to the surrounding area. But with the dirty shadow, you don't see anything meaningful behind it. It's all noise behind it. But it's a bit of a more whiter looking, as if it is echogenic area, but the fact that it's just all artifact and all pretty much noise afterwards. The other very common pitfall for the stone is a stone which is lodged in the gallbladder neck, and it's very common to not see it because it's just goes among all of that bowel gases and all of that. So it's very easy to miss that stone there. Again, one thing that we can do is to put the depth pretty much, to put this in the middle of the screen by increasing the depth and putting the focus at that level, at the level of the gallbladder neck, hoping that if there is a stone there, it's big enough to cause a shadow. And when you see that shadow, then you can recognize it. And again, the other thing you can do is to put the patient, if the patient is not tubed, if it is possible, put the patient in standing position or sitting position to make the fundus as the dependent part. So this stone, if it's not lodged, it would fall into the fundus and makes it easier to see. The other pitfall for the stone is that, if you remember, I was talking about the Phrygian cap with a fold. Again, if you don't fan completely through the gallbladder in the longitudinal view, we may miss that fold of the gallbladder. For example, we might think this is the gallbladder wall, and that is outside of the gallbladder, but the reality is that this is just a fold of the gallbladder, and this is the other part of the folded gallbladder, which is called Phrygian cap. And if there is a stone stuck there, it can cause problem, but you might think that it's just a bowel gas outside of the gallbladder wall. Again, from DDU exam point of view, all of these pitfalls for the stone are, at least for us, very common DDU exam questions to mention pitfalls for the gallstone and how to differentiate them. So this is what I was talking about with the stone being missed when the patient is in supine position, because the stone was somewhere in the gallbladder neck, but when you put the patient in the complete lateral decubitus to the point that the fundus is the dependent part, the stone falls into the fundus and becomes much more obvious. The other thing that might happen is the sludge. It's the same thing that as you would see in the sludge in the urinary bladder. So echogenic material usually doesn't cause any shadowing afterwards, and you can confirm this by, again, moving the patient and seeing that this sludge keeps forming a level based on your dependent position. It can actually accumulate and form a ball-like thing called a sludge ball, which can actually be looking like very, very similar and hard to differentiate from a very big polyp. And I guess if you put a Doppler, color Doppler on it, and you see some sort of perfusion in it, it can mean that it's unlikely to be the sludge, more likely to be polyp. But when there is no perfusion in it, it's a bit harder to differentiate. It can fill the whole gallbladder, and if it fills the whole gallbladder, you might miss the whole gallbladder altogether because it will look like pretty much exactly same as the liver. And the trick is to just look for the gallbladder wall, which you can still see. By the way, this is called the hepatization of the gallbladder. One of the main pathologies in the gallbladder that are important for us in both ED and IC is the cholecystitis. With the cholecystitis, there is several criteria. None of them are pathognomonic. It's just whichever criteria is added to what we can find, it just increases the probability of the presence of the cholecystitis. One is the stone itself. Having said that, we do have a phenomenon called acalculous cholecystitis, which happens in about 15-20% of the cholecystitis. You might not have a stone. Thickening of the gallbladder wall, so more than 3 millimeters. And if you can see, it's kind of a striated gallbladder, so it's not like homogeneous echogenic area like pretty much it. You can see some sort of striation in the gallbladder wall. The other thing is pretty much same sort of morphe sign that you get in the examination. You can elucidate with the ultrasound probe. So when you push with the ultrasound probe, it's quite tender, and you ask the patient to take a deep breath in if the patient is not intubated, and you can see the same sort of morphe sign with the ultrasound probe. The other thing is pericholecystic fluid like that, or maybe a little bit there, which would be a sign of cholecystitis. Again, this would be a quite common exam question, as in list the features of the cholecystitis. Again, there are some positive predictive values and negative predictive value. I guess the important thing is the presence of the stone, and either wall thickening or positive morphe sign is quite high. It increases the likelihood of the cholecystitis. And on the other hand, if there's no stone and no ultrasound morphe sign, it's quite good to say that unlikely to be a cholecystitis.
Payam, that's really important. That's certainly come up in the exam before, those two slides that you've had. I think that's probably the most common questions that have been asked regarding biliary ultrasound and the DDU. Those things, the sonographic features of it and sensitivity and specificity things. So thank you for bringing that up.
No worries.
I had a question. Basically,
yes.
Somebody who's ventilated and has acalculous cholecystitis, it's very difficult then with no stone and no tenderness, it becomes very difficult to then arrive at a diagnosis, isn't it?
Yes, so that's quite right. So technically you wouldn't be able to see either the morphe sign, and if the stone is just in the gall, you would still see the gallstone. It's just if it is lodged in the gallbladder neck, there's a chance that you might miss it. I guess you're right. It complicates the situation. I guess the thing that we can do probably in an intubated patient is especially to increase the chances of picking up the stone, all I can think about right now is to increase the depth so that the neck is in the middle of the screen, and put the focus right where the neck is, and fan through the neck. Hopefully, if the stone is bigger than your beam width, you should be able to see the shadow of the stone, and that should help pretty much guessing that, okay, there's a good chance that there's a stone in the lodged in the gallbladder neck. If the stone is anywhere else, or if there are multiple stones, you would still see them. With the tenderness, you're right, you shouldn't, well, I can't see how you can elicit the Morphy sign. You should still be able to see the thickening of the gallbladder wall and the peristaltic fluid. But obviously, as you mentioned, a patient who is tubed and cannot talk to you, and you cannot position them as we would be able to do in most of our ED patients, it makes it a bit more challenging.
Also, Payam, is there any criteria for drainage of gallbladder? Because often the concern in ICU is like, say, this patient has deranged LFTs. We do ultrasound, we see distended gallbladder. We're not sure whether it's a cholecystitis because we can't confirm with two criteria. And we have to kind of source control and drain, or put a drain in the gallbladder. Is there any kind of guidance around it?
To be honest, I'm not aware of any. Having said that, to be honest, because I never faced this sort of problem, I didn't even look whether there is any modified sort of criteria.
Hi, I'm so sorry to interrupt. Can you just excuse me for just one moment? The emergency buzz has just gone off. I'm just going to make sure they're okay.
Okay.
Excuse.
So we might, I don't know whether he wanted me to just pause or.
You need to keep going though.
Oh, okay.
So recording as well, remember?
Yeah. So just going back to where we were, this is again an example of acalculous cholecystitis. As you mentioned, it can be quite hard in a tube patient who cannot talk to you. You don't see a stone. All you can rely on is your wall thickening and peristaltic fluid. The other thing is that if you put some Doppler on it, you might see some Doppler intake in the gallbladder wall. And in normal situation, in a normal gallbladder, you usually don't see any flow in the gallbladder wall, but sometimes with this sort of cholecystitis patients, you do see some flow, which is again pointing towards hyperemia in there. Absence of it doesn't mean anything. It doesn't mean that you're good, but presence of it is quite suspicious. Again, gallbladder wall thickening, one common cause is cholecystitis, but one very common question in the DDU exam is the differential diagnosis for gallbladder wall thickening, because it can be thickened in a lot of situations other than the cholecystitis. As a general rule, there are 4 different categories. Some generalized edematous states like the CCF or end-stage cirrhosis or hyperalbuminemia. Lots of different inflammatory situations can do that. Cholecystitis itself, but chronic cholecystitis, cholangitis, even inflammation and infections in the surrounding area can cause thickening of the gallbladder wall. Cancers and adenomyomatosis. So again, this slide, at least for us, is something that we need to know by heart. Very, very common question. Complications of cholecystitis, probably this is actually, it might be more relevant to you guys than us, because this would be something that would be a patient who ends up in ICU probably with either empyema or gangrene of the gallbladder, emphysematous cholecystitis, or gallbladder wall perforation. And I've got some images of some of those. For example, in this one, you can see a quite thickened gallbladder wall with this sloughing of the mucosa inside the gallbladder, and you can see that pretty much echogenic material in the gallbladder, very thickened gallbladder, striated gallbladder wall, and that is an example of the gangrenous cholecystitis. Again, if you put some color, you might see some flow in the gallbladder wall. And interestingly, the sonographic morphine would be negative in 70% of these cases. So even if the patient is not tubed and you put the probe there and push, it might be that tender. Now, here is interesting. You can see that bright line there and nothing afterwards with a kind of a shadow, if you want to call it. And you might think it's that either porcelain gallbladder or a big stone, a huge stone completely filling up the gallbladder. I think the giveaway is that reverberation artifact looking sort of shadow, as in a dirty shadow, which is more in line with gas rather than a stone or any other classification. It usually happens with a gas. And this is a bit more obvious with all of those pretty much air fluid levels in an emphysematous cholecystitis. Again, this might be a question that you might get in the viva, as in they would show us this ultrasound sort of pictures and would say just, what do you think about it? I just pass on this because we are running a bit late and it's not that common question anyway, adenomyomatosis. One thing that might come as a common question as a differential diagnosis for a stone is the polyps. You can see teeny tiny sort of echogenic area, and you might think that they are in the middle of the gallbladder, but if you fan enough, you see that it's stuck to the gallbladder wall, same sort of echogenicity as the gallbladder wall, and they tend not to cause any shadow. And that would be the main difference between them and a smaller stone, because they are very easy to be mistaken with a smaller stone. They are invariably attached to the gallbladder wall. Even if they look like that, they are not. If you fan, they will look that you will see that they are attached to the gallbladder wall. With the polyps, there is no consensus, at least until about 6 months ago when we were searching, there was no consensus as in what to do with them. But as a general rule of thumb, depending on how big they are, there might be some follow-up ultrasound or surgical removal of them. Obviously, the bigger they are, the higher the chance of them getting malignant later on. Again, I don't know whether it would be a common question for you guys, but for us, it's a common question, as in what to do after after visualizing a polyp. The other interesting thing is, again, this is a common question. If you can see, there are two tubes running just side by side each other. Again, remembering from the anatomy, the biliary system and the portal system run together. Usually with the portal vein branches, you just see them on their own because the intrahepatic bile ducts are so small that usually you don't see them, or if you see them, it would be very teeny tiny looking thing. When it is two quite similar sized tube or sizable tubes next to each other, it means that pretty much that intrahepatic biliary duct is quite enlarged, and that's called the track sign, train track sign, or double track sign, and it's a sign of intrahepatic duct dilation. And if you follow the CVD on this one, this is a quite big CVD. If you measure it, it would be much more than 6 millimeters in somebody who still has the gallbladder, and there's a stone lodged in the distal part of it with this clean shadow afterwards. Again, this slide would be a very common question for us in the exam, in either viva or the written part. Common pitfalls with the gallbladder, the sort of things that we just mentioned, mistaking the bowel gas or the duodenal gas with stones. Contracted gallbladder can be misinterpreted as a calculus cholecystitis, a sludged filled gallbladder, which would look like the liver, and it might get missed. And I'll just pass on it because we just mentioned all of them. but this slide would be a quite common question as well. Now, if we want to go through some images, do we still have Ravi and Hatim? Hello?
I hope
So, Ravi, do you want to just treat it as a pretty much viva question, as if they have shown you this image and ask you to just interpret the image?
Yeah, so it looks like a focused longitudinal view of the gallbladder on a 2D image. It shows possibly a dilated gallbladder and hyper echoic shadow on the posterior wall of the gallbladder, which is echogenic. It seems to be attached to the wall, but I would like to see more images. I don't see any post-acoustic shadowing there. So there could be differentials like polyp or maybe a gallbladder sludge or malignancy. So I would like to do a Doppler to look at the vascularity and image it in different planes to first ascertain the abnormality and maybe change the position of the patient to see whether it is mobile.
Perfect. So pretty much, I don't have anything to add. So exactly. So
that was a pretty good answer, Ravi. I thought that was pretty good.
Yeah, it was perfect answer. So to be honest, I don't have anything to add. So echogenic structure with no shadow after it, as you mentioned, it can be either malignancy or sludge ball or a big polyp. You can move the patient, see if it moves. You can put some color Doppler on it, see if it has some flowing. Now, I think, do you want to describe this one?
I'm sorry, her team got called away. I did a wonderful consultant thing, then I got her team to sort out the problems. And left him dealing with it, so he's gone. I do have Anne-Marie here, though, who's our Echo Fellow. And maybe we got a team Nepean go.
I think I know Anne-Marie from Burnley Hospital. If you remember, you were my consultant when I was a SRM model.
Oh, there you go.
Nice.
I did work in Burnley. I did not remember you, sorry.
But did you work at Burnley around 2011?
Yeah.
There we go.
There you go.
Okay.
So again, another focus view of the gallbladder long axis view. This time there's two echogenic shadows. There's one anteriorly, which is casting an acoustic shadow deep to it. So looks like it's probably a stone. And a second one on the posterior wall of the gallbladder towards the neck, which is not casting an acoustic shadow. So, although it may be actually. So I'm not sure that that one is a stone. The gallbladder wall looks slightly thickened. There's no pericholecystic fluid. Again, I'd want to image in different positions and also ask the patient if there was any pain to establish if it was cholecystitis or if it was just gallstones.
Can you move them around as well? Imogen, did you say that?
Perfect. So again, perfect answer. And we don't have the sides of the screen to see where they have put the focus on this one, but I assume they have optimized the image for this one because you can see a very good going shadow there. This one is still do create a shadow, but probably we won't see it because this is one side of the shadow and the other side of it pretty much is being hidden in the neck of the gallbladder wall and that area. And that's why I was saying, if we want to see the stones in the bladder neck, the best thing to do is to increase the depth a little bit, to put the neck in the middle of the image and put the focus at that level, and that helps seeing the shadow a bit better. I think we don't appreciate this shadow. Part of that is because pretty much we don't have enough depth to see a good going obvious shadow like this. Does it make sense?
Yeah.
The other thing, the important thing that I didn't mention is that it's very important when you are measuring the gallbladder wall. We measure it where it is perpendicular to the beam, the ultrasound beam. For example, there, okay, if you can see the wall properly. In this specific one, you cannot see the gallbladder wall properly there. If you measure it there, it might be falsely looking thick, because then you are getting a beam width artifact, okay? So technically, the width of the beam might actually smear the, any sort of object that you have. It gets smeared laterally, as in half of the beam width to each side, okay? Technically, with the ultrasound, point-of-care ultrasound machines that we have, if you imagine a curved probe, your beam widths, even at focus, are several millimeters. So it can easily have several millimeters of the lateral resolution, which means it can actually increase the gallbladder wall measurements by good 2 or 3 millimeters, which can actually put it into that abnormal range. So we use it where we can actually rely on the axial resolution of the ultrasound rather than its lateral resolution. Does that make sense? So in that case, back to Ravi. So is it, we have Ravi and Anne-Marie only now?
Yeah, and there's also, we do have Swapnil and Lee. They're normally up for answering a few questions. They don't mind answering a question or two.
Thanks, Sam,
Am
for
I okay
under the
speaking
bus.
on your behalf?
Thanks, Sam. I know you always throw us under the bus, but that's okay.
Absolutely.
I will look. I'm far from DDU, but I'll attempt. That's fine. So again, this is a focus examination of gallbladder longitudinal view. It seems the gallbladder wall seems to be quite, like, not quite, but it's thickened. And again, probably need to compare in different planes. And there are two rounded hyperechoic shadows inside the gallbladder cavity, and one is attached to anterior wall, one is attached to the posterior wall, but they both are not producing any post-acoustic shadowing. So could be, again, differential, could be polyps, or it could be sludge ball. But probably like to, again, change the position of the patient, and also probably put some Doppler and see if there's any vascularity of that structure. And probably do Murphy's sign as well, like, if, I don't know, the resistance to correlate with that.
Excellent. And as you mentioned, changing the position of the patient, see if it moves or not. If it moves, it's a small stone. Again, I don't know, the exam technique wise, if I want to, because at least for us, I've heard a lot that they expect us to say what would be our primary diagnosis and then what would be the differential diagnosis. If it was me, I would say, for example, in this one, my primary diagnosis is sludge ball. The differential would be the rest of the things that we mentioned. In this one, as you mentioned, there are several different possibilities, but my primary diagnosis, my primary suspicion would be a polyp with a differential diagnosis of a stone, and exactly what you mentioned as what we do to differentiate them. Now, that wall thickening that you mentioned, I assume you were thinking about here. Is that right?
That's right. Yeah.
Look, again, if you look at this part of the gallbladder wall, it would definitely feel within the normal range. This looks a bit thicker, okay? If you imagine this is a curved probe and the beam is coming from there, hitting that part almost perpendicularly, almost, okay? Or at least almost perpendicular. But when it reaches there, it's almost 45 degrees, yeah? So technically here, you are using your axial resolution. Therefore, it doesn't look that thick because it's a bit more perpendicular to the beam width direction, the beam, the beam ultrasound beam direction. But here, because of the way it's lying in comparison to the probe interface, it's much more oblique in relation to the ultrasound beam direction. Yeah. So again, the same thing happens as I explained in the previous slide, that in this one, because a lot of it falls into the beam width of the ultrasound with a lot of lateral resolution involved, it gets smeared, okay? And that might falsely look thickened. And as you mentioned, to be 100% sure, what I would do would be to go to the transverse view, get the patient to take a deep breath, to bring it a bit lower, and try to get a perpendicular sort of view of that wall and measure and pretty much have a look at it there. And that's another reason why we tend to measure the anterior wall and not the posterior wall.
Thanks.
Does that make sense?
Yeah, absolutely. Thanks.
No worries.
I have a question, Payam.
Yes?
In the exam, do they give a bit of clinical stem, like why we are doing the ultrasound? That way we can prioritize the differentials.
Absolutely. I think it's probably the same for the ED ones as it is, or the general DDU as it is for us. So for the ICU DDU, it's always a stem, and then anywhere between 1 to 10 images you'd have to review. And so I think it's very similar. So absolutely, clinical context is a really important part of analysis.
Oh, perfect. You're absolutely right. I think for the next time, I might change them in a way that I put some stem to them as well.
I'm sorry, Lee is away from his keyboard at the moment, so you've just got to put up with us, Payam. So
okay. So who's next? Is it back to Ravi?
So this is, I think we have seen this image before. This is a focused view of the. It looks like a dilated gallbladder and a dilated common bile duct with hyperechoic shiny shadow along the arrows and a post-acoustic shadow. So it looks like stone in the common bile duct, intrahepatic common bile duct.
Perfect. That was a good answer as well. I might go through them a bit quicker for the interest of the time because there are 6 more and we are almost done with the
yeah, I'm afraid to say we might have to just make it 1 or 2 more done.
Okay, in that case, Anne-Marie, do you want to go for this one? I think you're on mute, Sam.
I do apologise. She was doing a great job. I was learning heaps.
Sorry, another long axis view, focused gallbladder. Axial thickness looks more than 3 millimeters this time. There is some pericholecystic fluid, and there is an echogenic lesion at the neck of the gallbladder with a little bit of a dirty acoustic shadow. Again, I'd want to ask the patient if there was any pain on the tenderness, see if there was Murphy's positive, but I'd be suspicious it was cholecystitis, calculus cholecystitis.
Perfect. And that is exactly what I was mentioning in the earlier slides about the dirty shadow versus the clean shadow. If you increase the gain, and you can see that the gain is a bit too much with this very hyperecho area here, you would see some echogenic material in it. But if you compare this kind of a shadow to a kind of a shadow that you would see, again, because the physics mechanism is exactly the same as the B lines in the lung, it's a bit different from that kind of a shadow. It's still a clean shadow, which would be looking a bit different from that kind of a shadow, which you can see it looks like a B line going down, yet almost. Where are we? Actually, this is a good one as well. So Anil, do you want to go for this one?
No, I don't have any idea about this one, but it looks like a large gallstone with a very acoustic shadow, post-acoustic shadow. Is it, or with there's a space between? No, I'm sorry, I don't know.
Oh, no, so I think you were not here when I was talking about the difference between this.
WAES. Is it WAES?
Exactly. Perfect.
Okay.
Yeah,
okay.
perfect. So the difference between that and that. So this is a porcelain gallbladder with pretty much hyperecho wall because of the calcification of the wall without any And in this specific porcelain, you can see the posterior wall as well. But in this one, you can see the west wall echo shadowed sort of triad. And this is a big, huge stone, pretty much filling the whole gallbladder.
And remind me what it stands for again. It's the wall enhancing.
Wall echo shadow.
Wall echo shadow. Thank you.
Thanks.
Okay. So I think you wanted me to just go through a couple of more images, and that's pretty much it.
Yeah. Payam, thank you so much. That was another great lecture taking us through that. Thank you very much. Were there any questions for Payam?
In terms of documenting the images, what are the minimum number of images required, or most optimal number of images, and what planes are required to document a full study?
Yeah. So it depends on, for example, for emergency DDU, I can say whenever I document images, it's about 40 images or so. But I think if you are going with if the requirements for you, as Sam said, is CCPU sort of images, then it's going to be one image of the liver to show that there is no intrahepatic duct dilation. And that would be one sagittal and one transverse. Then you want to have a long view of the gallbladder with the gallbladder neck in the view, in the supine position or in the semi-lateral position. Then in the same sort of initial position, you want to have two transverse views. One is the fundus of the gallbladder, the other one the neck. And then you want to move the patient towards either a standing or sitting position and have another long view. And then your CBD, and that's pretty much it.
So that's all total about 10 images or so then?
Yeah, 6 or 7 images, yeah, 10 images.
Well, let's go. Are there any other questions for Payam? Well, Payam, if there are no other questions, I just want to say again a huge thank you very much indeed for joining us again and teach us about the biliary ultrasound, and hopefully see you soon.
Pleasure, yeah, next time. See you next time.
Thank you very much.